The Apollo Dissemination Working Group and the American Society of Transplantation are very pleased to present Best Practices in Next of Kin Research Authorization after Consent for Organ Donation. Today's presentation will be led by Dr. Krista Lentine from St. Louis University and Dr. Silas Norman from the University of Michigan.
Well, thank you, Brian, for the kind welcome, and our sincere thanks to the American Society of Transplantation for supporting this collaboration. I'm delighted to introduce today's program on best practices in next of kin research authorization after consent for organ donation. This is the first of a two-part video series on an important but under-recognized topic. And we're starting with a video directed towards professionals working in organ donation and transplantation, and then a community-directed video will follow. But truly, we welcome engagement and feedback from all audiences across the series. I'm Krista Lentine from St. Louis University. I'm one of the co-PIs of one of the 13 Apollo clinical consortia, working with Dr. Dan Brennan at Johns Hopkins. I'm also chair of the Apollo Dissemination Working Group, a longstanding member of the American Society of Transplantation, and current chair of the AST Living Donor Community of Practice. And I want to thank the entire Apollo Dissemination Working Group for their time and support of this video series. My co-moderator today is Dr. Silas Norman, and we are grateful for the time of our wonderful panel, including NIH leadership, expert staff from an organ procurement organization, as well as two generous and insightful donor family members who are taking time from work and responsibilities to be with us today. I'd also like to highlight the valuable partnership with organ procurement organizations in Apollo and thank Mid-America Transplant in particular for sharing expertise on this program. Mid-America enrolled the first deceased donor in Apollo and have been exemplary partners in the research mission. And we're delighted to have leaders from their team with us today. So now Dr. Norman will give a brief overview of the program and welcome each panelist to introduce themselves.
Thank you, Krista. I'm Silas Norman. I'm a transplant nephrologist at the University of Michigan, and I'm the past chair of the AST Ideal Committee, which is the Inclusion, Diversity, Equity, and Access to Life Committee. Our program today will include a discussion of categories of deceased donor research and the importance of next of kin authorization for research. We will briefly review the Apollo study. We'll review why next of kin research authorization is vital to conducting this national study of kidney transplant outcomes, and why the success of Apollo is important for the broader community. We'll hear from donor family voices on what is the most important in discussing authorizations for research after consent for organ donation with families, and then build to best practices for these discussions from a donor family services specialist, including an informative role play exercise with a donor family member. I'm pleased to welcome our fellow panelists. Dr. Rolanda Schmidt.
Thank you for having me. I am Dr. Rose Schmidt, and I am a business professor. And sadly, when my son passed away, I became a donor mom, which also pivoted my career into becoming a pastor. So I also have the role of chaplain intern at a trauma hospital, and I look forward to talking more during this session.
Thank you for being here. Jennifer R. Davis.
Hi, thank you so much for that welcome. I am very honored and pleased to be here today. I am representing the donor family. My brother was first a recipient and then later became a donor. I also represent Mid-America Transplant Foundation Board, on which I am proud to serve as a member.
Dr. Jonah Odom.
Hello, I am the chief of clinical transplantation section, transplantation branch at the National Institute of Allergy and Infectious Diseases, and one of the NIH members of the Apollo Steering Committee. in addition to being a member of the Apollo Dissemination Committee.
Good morning. Dr. Gary Markland.
Yeah, I am the Chief Medical and Research Officer at Mid-America Transplant in St. Louis.
Good morning. And Wendy Rose.
Good morning. I'm the Manager of Family Support at Mid-America Transplant in St. Louis.
To start, Dr. Markland, could you start us out by please telling us about the various types of deceased donor research?
Sure. I think there's several different types of deceased donor research. One would be for organ transplants and organ donors. And in this type of research, it is studies that are trying to improve the quality or the quantity of organs to be transplanted. This research is done prior to transplantation, and most donor families are in favor of this type of research because it will maximize the number of organs to be transplanted, which would save more lives. Another type of research is for tissues and organs that are not going to be transplanted, mainly because the quality of the organ is suboptimal. This type of research would be done after all of the other organs to be transplanted have been recovered. A primary example of this would be a person who has hypertension or diabetes and has chronic kidney disease. Well, the kidneys can't be transplanted because of the disease, but they can be studied to find new treatments and cures for chronic kidney disease from hypertension or diabetes. And then lastly, we do studies looking at genetic factors in the organ donor that could lead to certain types of diseases. An example of this is the APOL1 gene, which we can study. It's a gene that's been associated in the African American community with some chronic renal failure, chronic kidney disease, and can actually lead to transplantation at some point in time if they have the disease. We can measure in the donor a simple blood sample to find if they do have the APOL1 gene. And this would be important for both the recipient and the transplant surgeon in managing this kidney from a donor that potentially has the gene, as well as the donor family, because if the donor has it, it may very well be in other family members.
Thank you for that, Dr. Markland. So why is participation in deceased donor research important to advance and optimize organ use and transplant outcomes?
Well, we've been doing organ transplantation for more than 40 years, and you would think that we would have figured out the best way to manage an organ donor. In actual fact, we don't know that. We are still doing studies and learning better ways to manage the donor to increase the number of organs. At Mid-America Transplant in the last decade, we've done multiple studies that have provided results which have allowed us to change the way we manage a donor to increase the number of organs transplanted. A perfect example of that is our prone study, where we found out that if you have an organ donor and you put them in the prone position, basically lay them on their stomach for 12 hours, it improves their oxygen level, and we were able to transplant twice as many lungs from these donors. This has been published, and now other organ procurement organizations are proning their donors, and we're increasing the number of lungs being transplanted. So the study needed to be done and the results published so that we can change and have this effect. We are also collaborating with other researchers on organs and tissues that are not transplanted. We are doing a study with retinas in the eye with collaborators looking for genetic factors that are causing age-related macular degeneration, a significant cause of blindness. We're also working with other researchers looking at pain. They're studying peripheral nerves as well as part of the spinal cord responsible for pain. And they are making great strides in finding out the causes of the pain and trying to find new cures for pain. So these are very valuable studies in these tissues that give us great scientific knowledge to hopefully improve treatments and cures in the future.
That's great information. Thank you very much for that, Dr. Marklin. So turning now to you, Dr. Odom, you were part of NIH leadership of a national UL1 study of kidney transplant outcomes that involves all organ procurement organizations and transplant centers in the country called APOLLO, or the APOL1 Long-Term Outcomes Study. Dr. Odom, would you please give us a brief overview of the APOLLO study?
Certainly. Well, African ancestry is associated with an increased risk of kidney failure in the general population and after living kidney donation. Moreover, kidney transplants from deceased donors with African ancestry have an increased risk of graft failure compared to organs from non-African ancestral donors. Recent breakthroughs in medical genetics have revealed a portion of kidney failure affecting African Americans is mediated by genes. And those genetic variants, not race, account for that increased risk. Kidney risk variants in a gene called apolipoprotein L1, ApoL1, are present only in persons of African ancestry, inheriting two risk variants, one from each parent, is associated with an increased risk of kidney failure. And this high-risk genotype is present in approximately 13 to 15% of African Americans. Importantly, preliminary evidence suggests that deceased donor ApoL1 genotype may impact transplant outcomes, and living donor genotype may impact health after living donation. Of note, though ApoL1 high-risk genotypes do not sentence or destine a person to develop kidney disease or a kidney allograft to fail, rather additional genetic and/or environmental risk factors, sometimes called second hits, are likely required for disease progression. These additional risk factors or hits may include environmental and social determinants of health, as well as biological factors. For example, in kidney allocation, the Kidney Donor Profile Index, or KDPI, is used to evaluate organ offers from deceased donors based on several factors, such as age, history of diabetes, and history of hypertension, as well as Black race. Organs with higher KDPI score are more likely not to be used for transplant, an outcome called non-utilization, or formally discard. Categorizing race as a biological construct rather than a social political one contributes to healthcare disparities in kidney disease treatment and transplantation, including organ acceptance practices. Apollo seeks to perform ApoL1 genotyping in a national cohort of deceased and living kidney donors to, first of all, better define the quality of deceased kidney donors and scoring for organ allocation, and to improve organ selection and using the right kidney for the right patient.
Thank you, Dr. Odom. And now, could you tell us why next of kin research authorization is vital to conducting this national study of kidney transplant outcomes? And further, why the success of Apollo is important to the broader community?
Well, Dr. Lentine, the primary enrollment target of Apollo focuses on deceased donor and recipient pairs. The eligibility criteria are simple: donor African ancestry and the presence of research authorization. In the United States, research on the deceased donor's body and/or organs is permitted under the Uniform Anatomical Gift Act. If the decedent previously authorized such research through first-person authorization, in the absence of the deceased donor's documented decision, authorization for research related to the decedent's organs, tissues, and specimens requires consent from the next of kin. Therefore, in the case of first-person authorization, this hearkens the importance of informing one's next of kin and loved ones about intentions to be an organ donor and participating in research. Apollo represents NIH's commitment to address the long-standing challenges of implicit bias, structural and cultural barriers faced by Black and Brown populations in the United States. In funding Apollo, the NIH aligns with its overall mission of reducing the overall burden of disease, reducing disparities, and increasing access to healthcare and biomedical research. The identification of 2 genetic markers unique to Americans of recent African ancestry that are associated with developing kidney disease may improve the evaluation of deceased donor kidneys, reduce rates of kidney non-utilization or discards, and provide a more precise biological and personalized risk assessment of living kidney donors. The Apollo project, clinical design, and execution is a vanguard example of walking the talk with respect to addressing disparities in cutting-edge biomedical research from the perspective of clinical trial design, conduct, and participation. The study is also unique for its national scope, design, and collaboration with all stakeholders in the U.S. transplantation ecosystem. Attaining the requisite study power to address the hypothesis in a timely, efficient, and cost-effective manner is difficult in transplantation research, given the small cohorts, the lack of study control over the organ allocation system without centralized coordination and collaboration at a national level. Importantly, observations from Apollo, as well as recent analysis of data from Mid-America Transplant OPO, led by you, Dr. Lentine, shows that deceased donor research authorization decline is higher for Black and other non-white deceased donors compared to white donors. Disparities in donor research authorization in the Black community can pose barriers to studies that seek to improve allograft quality scoring and organ utilization, and to improve the outcomes of the community in need of kidney transplants, such as Apollo.
Thank you, Dr. Odom. Now I'd like to turn to you, Dr. Rowe. So, Dr. Rowe, from your perspective as a donor family member and also as a chaplain who serves families during the sensitive time when organ donation and related issues are discussed, what often goes through the minds of donor family members when they hear the term research after consenting for organ donation?
It is very stressful when, from the perspective of me as a donor family and when I'm a chaplain intern, to hear just the word research amongst the individuals that I'm talking or hearing it. Often I find that from the minority community, when someone hears research, it sounds like inhumanity is rampant and their family member is not a human being, that we're looking at that person as a commodity rather than a human who's, they've lost, or someone that suffered. So it's important specifically to not use things like clinical studies or research and just meet the family where they are and use discernment and wisdom when we're speaking, no matter if it's me and medical or OB that are talking to the family.
Terrific. And would you like to comment a little bit on your experience of serving families as a chaplain?
Sure, yes. In my role, I am learning under many other chaplains. I'm becoming a pastor and going in the role of a chaplain intern. And I recall just being with a few families where the first comes to their mind, even whether they have trepidation before signing the paperwork to allow their loved one to give organs, or whether it's deciphering whether I should do this, the first thought that comes to their mind is, oh no, the hospital wants to snatch my loved one's organs, and they're going to use it to take everything away from me. And it's with good reason, given the history of what African Americans have gone through in history. And so just to first meet them with love and listen first to the great things about their family member, and then go into the only aspect I can do at the time, just listen to them and kind of tell them a little bit about what I know about organ donation and how wonderful it is, and that the hospital is not trying to harm them. But the trepidation is real. It is real. I've seen it in many, many families, specifically minority families being at the highest rate of not having comfort with someone coming in talking about transplantation or any other aspect. So it's just something to keep in mind, using discernment, kindness, meeting that family where they are, and taking the time and compassion prior to talking about anything to do with clinical studies or research, just not even using that word.
Thank you, Dr. Rowe. Jennifer, I want to thank you for bringing your perspective as a donor family member and as a member of an organ procurement organization foundation board. We know that you're going to work with Wendy in a role play exercise in a moment. But before that, do you have any general thoughts on what professionals need to keep in mind when approaching donor family members for research authorization after consent for organ donation?
I would pretty much echo the sentiment that Dr. Rowe has already given. I think that the timeliness of the approach is also something that needs to be considered. The content, but keep in mind when you engage with the family members, again, the nuance of the word choice, the content, be sensitive to what we're asking us. As Dr. Rose said, historically, we've been used for various projects. And so that also lays within us, and that we don't want our loved ones to be discarded or treated as trash, so to speak. And so I would say to any professional that is approaching a family and haven't been approached myself, again, just remember the sensitivity of it. Remember to not use those words of research, as Dr. Rowe has said, be sensitive to the words that you're using as approaching a family. If a loved one and a family have already had this conversation, then it might not be as challenging to have that conversation with someone if they've already had that discussion. But again, you won't know that unless you approach the family, or the family has specifically said that that is their choice. This is a reminder to all of us to express wishes to our family. They can be hard conversations, but it's the best way to have your wishes honored.
Thank you so much, Jennifer and Dr. Rowe, for sharing your experiences and insights. As mentioned, we are going to include an important role play exercise, but first we wanted to ask Wendy for your thoughts on key principles and best practices for requesting research authorization for families after consent for organ donation.
Sure. And what you're going to hear from me is very much an echoing of Jennifer and Dr. Rowe. First and foremost, taking the time to build rapport and gain trust with a potential donor family. they're going through a really terribly traumatic time, and our primary goal is to support them, no matter the outcome of our conversation. I always try to learn as much as I can about this potential donor hero. I ask to see pictures, I ask questions about them. I really just let their loved one share memories and talk about them. The families can often feel that this request for organ, tissue, eye donation, research donation is transactional, and that their loved one is just a number. Families need to feel that they are cared for and respected, and they want to know that their loved ones and their gifts that they're giving are also going to be treated with that same respect and care. It seems elementary to say, ask open-ended questions, but really, asking those questions and not assuming, just because someone wants to donate organs and tissues, they may have different feelings regarding research or clinical studies. It helps to clarify also, as sometimes it takes a few questions to really, understand what their true concern is. Never minimize someone's trauma response or invalidate their feelings about research or clinical studies. Even if the concern is one that we know has shown to be non-factual. One I can come up with is, we're going to sell their organs. Their concerns are real and should be treated as such. It also helps not to have that conversation for organ and tissue and for research in one big chunk. A family's capacity for information is limited, when they're in times of crisis. And so it helps to piece that conversation out in smaller chunks. You gain agreement and understanding after each small discussion. And so then it doesn't feel so overwhelming to the family. And then in this way, we're also just helping them to process each small discussion and process that information as they receive it. And so then we know they're going to be more likely to retain it. And lastly, and this is important, treat research and clinical studies just as importantly as you do organ and tissue donation. When you mention it as an afterthought, or you talk about it dismissively, saying something like, oh, and if we can't find any recipients, we'll just look for research or something. The family's perception is that it isn't important, and their knee-jerk reaction is likely going to be to say no. So sometimes it helps to give examples that they're going to relate to personally. If their loved one has heart disease, for example, it would help them to understand that if we find a clinical study for the heart, it could help others in the future to not develop heart disease.
Thank you very much, Wendy. And Dr. Rowe, I wanted to ask, any reflections on what Wendy just shared, particularly for Black families and families of color?
Everything that Wendy said, I echo 100%. It takes me back to the day of, sitting with my family, holding my son's hands in those last moments, realizing that his organs were going to go to people who needed them. It's a tough situation, very stressful, painful beyond painful. But knowing that the OPOs care, the medical staff cares, and treating people with respect is important. And then I would just add to what she's saying, when she talks about big chunks, even, I believe it's so important to ahead of time with advocacy in like maybe partnering with the driver's license place and places like that to let people know what organ donation is, because sometimes we believe that people just know automatically, hey, here's a check in the box, this is what it is. But if more people know ahead of time, it would make the work a little lighter for those when they come to the hospital with a tragedy, that they would have already heard about. This is what organ donation is. Here's stories that are successful of family of color that have received organs. And that's a lot of work, but I'm just putting it out there that I believe that's important. Lastly, as Wendy said, I love to talk about acknowledging people's trauma response. You just don't know what somebody is thinking, what they've been through, what they've been told. So just taking the moment, being respectful, taking that time to hear their voice, makes them feel more comfortable, because they're about to give and grieve at the same time. And they just need to know that they are heard, they're supported, And that rapport and trust, as Wendy mentioned, is continuing to build. So thank you for saying the acknowledging our families.
Well, thank you all so much. There's really no substitute from hearing these perspectives directly from the viewpoint of donor family members. So we really can't thank you enough for sharing with us today. So now let's put some of these principles in action in a role play scenario. And Jennifer and Wendy will illustrate some of the key principles in a role play interaction. For this scenario, we will assume that the initial broader approach for organ and tissue donation has been completed, and the family has already expressed that they're interested in donation. And while taking the next steps, the opportunity for clinical studies is introduced. So please take it away, Wendy and Jennifer.
As I mentioned earlier, Jennifer, your uncle could help save and enhance so many lives through the gift of organ and tissue donation. Our primary goal is always to find recipients for his gifts, but sometimes if we are unable to find recipients, we do try to help others through donation for clinical studies.
So what does "if we are unable to find recipients" mean? I thought that he would just donate the organs and the tissues to save someone's life or help them directly. Are you talking about using them for research?
Yes, I am referring to research. Do you mind if I take just a few minutes so that we can talk through what those clinical studies are and how he can still help others in that way?
Absolutely, but it doesn't quite sound like something my family would be interested in. We don't want him to use as someone's science project.
Oh, absolutely. And that is, not what we want either. I want to make sure that you have all of the information you need to make the best decision for your family. You had said earlier that what does that mean when we're unable to find a recipient? And sometimes that's just that a person's organ isn't medically transplantable, or maybe that we can't even find a recipient. So the types of clinical studies I was referring to would be those that actually help to find treatments or cures for certain diseases. Would it be helpful if I gave you specific examples?
I don't know. I feel like he would want any of his organs or tissues to be used to save a life, not for research. Historically, my race has been used as guinea pigs for various research projects, which used inhumane techniques for pointless data collection.
And thank you so much for sharing those concerns with me. And I know the thought of an organ or tissue not being used to directly save a life, it seems opposite of what you're agreeing to. And I can certainly understand your family's mistrust of research, given the historical background of research in your community. Please know that I hear you, and I truly appreciate your being open to even just having this conversation. The clinical studies that our organization partners with are designed to be another way for our donor heroes to help others. And that's why we offer these opportunities to maximize the gifts that our donor families can give.
Well, we would want to help as many people as we can. And that's the kind of person my uncle was. He would help anyone in need just because he felt that was the right thing to do. You said you had specific examples of research. Can you give me one?
Absolutely. Earlier in our conversation, you had mentioned that your uncle, he didn't really go to the doctor or take medications and maybe had high blood pressure. A current clinical study is one for patients that have a genetic form of chronic kidney disease that isn't caused by diabetes, but is instead caused by variations in one of their genes. These kidney risk variations are only present in persons of African ancestry. So he would be helping people in your community and possibly help many people who need kidney transplants in the future. None of his identifying information would be used, but his contribution to that study could be so helpful to the doctors and scientists who are studying that gene.
Okay, well, that does sound like something that would be helpful. And I think he would be proud to know that he helped people in our community. I think we would be okay with the research as long as it was a benefit to others. And again, just not someone's pet project.
Oh, absolutely. And thank you so much, Jennifer, for agreeing to help others in this way. We would be able to let you know about the clinical studies that his organs, tissues, or blood samples would be donated to. And again, none of his personal information would ever be used in any study to protect his and your family's privacy. Thank you.
Thank you.
Thank you, Jennifer and Wendy, for that excellent demonstration. As we close the program, we wanted to ask for final thoughts on how the OPO community, transplant professional, the NIH, and other agencies can work together to share best practices. And so I might ask Dr. Markland to comment, and then Dr. Odom, if you could give some comments as well.
Thank you, Dr. Norman. I think it's important for the OPO community to continue to pursue, these donor management research projects because the results are so important in terms of improving the quality of the organs to be transplanted. And when these studies are done, they need to be published and shared with the scientific community. But I also think they need to be shared with the public so they realize that it's from these studies that we're gaining this knowledge to improve the number of organs that can be transplanted. And it's only through these research studies are we going to get better.
Dr. Odom.
I couldn't agree more with the last comments. Clearly, the Achilles heel of transplantation has been the chronic organ shortage, and donor interventional research bodes well for trying to mitigate this shortage by increasing donor supply. So I think it's very, very critical that the populace, patients, and the people understand what transplantation is about and help solve this critical issue of organ shortage.
Well, thank you so much for those final and very impactful comments. And on behalf of the Apollo team, we want to thank our wonderful panelists, as well as my co-moderator, for their time, expertise, and contribution in sharing expertise about best practices in next of kin research authorization. In our next video, we will explore the topic from a community perspective. And to our audience, thank you for your time in listening to this program, and we welcome your ongoing engagement and discussion. And again, thank you to the AST for joining with us in this collaboration.